All right, and how do we, thank you. So thank you for having me here today. It's always a pleasure to talk with the folks in the home health world. I'm typically the person that's pulled in to look across the providers and think about the populations and think about the policy implications. So I was asked to put home health in the larger health ecosystem perspective. So I'm going to present a little bit about the changes that are going on in the healthcare environment in which home health is operating, as well as some of the talk a little bit about the role that home health has traditionally played in the Medicare program, and put up a statistic that's probably going to shock you a little bit, because we talk about home health as a medical service, but it's really in the middle. It's both the medical and the social support services. And then talk a little bit about what some of mine and others' past research has shown about the role of home health in terms of the relative resources that are provided in a home health agency compared to other healthcare providers, and more importantly, the value. There have been a lot of debates about what is the role of each of these different providers in these changing environments, and we actually have some data. And then lastly, talk a little bit about the opportunity, because I think home health is one of the most underused services in the country, but it's just my opinion. So, this one? Okay. So today's evolving healthcare environment, we hear these words tossed around. The Affordable Care Act has focused us on the triple aim, that aim of improving quality, improving population health, reducing cost of care. And the big difference there, those initiatives were always underway, but nobody pulled them together into one related effort. And that's really what a lot of the work is. There's a new focus on patient-centered episodes, not just the service that was provided in one setting. There's a mandate as part of the ACA, the mandate for all of the Medicare services to now have a quality reporting program in place. And that was a big deal. We're always familiar with the hospital quality. The nursing facilities have been reporting on quality forever. But it wasn't until the ACA that they put, or it might have been the legislation right before, that they put the mandate in that everybody should be paying attention to quality. And then the innovative payment methods that are not only focusing on the cost of care, but the outcomes, starting the conversation about the value of care, not just continuous payment for additional services. And we've seen a lot of changes, even the slow changes, the quality adjustments in the fee-for-service payments in hospitals. You hear all the talk about the readmissions programs. Well, those are seeping out into the other areas of services also. There's now consensus that avoidable readmissions are really bad and something should be done about them occurring. Value-based payment systems to actually incorporate some of those outcomes into the payment. Shared savings, where the discussion gets broadened and it's working across all of the different parts of the system. The accountable care organizations are often starting with the hospitals. Well, now they have to start talking to the other parts of the system because they're accountable for that patient's outcomes. The Gainsharing programs targeting the physicians, the medical homes, the physicians, and some of the community. The bundled payments, all different entities are taking the risk there, but it's all about coordinating care. It's about incorporating outcomes as we think about payments for services. There are additional programs that are targeting specific populations, the dual eligible coordinated care, all the managed LTSS, long-term services and supports programs that have been established this year. Even on the Medicaid side with the rebalancing initiatives. You know, we had a conference back in December where we brought together people from the Medicare affiliated communities, the Medicaid, and the Administration for Community Living to really think about whether it's your high-cost population in the Medicare program or it's your LTSS population in the community living revenue streams. You're all talking about the same people in the community. These are the more complex beneficiaries who have a lot of issues going on, and some of the needs are medical and some are social support. And I think that's really where home health comes into the picture. And there are additional innovations, not only in the public insurance sectors, but many of you are meeting them in your private insurers. So what role can or should home health play in the changing marketplace? Well, as a service, it really is that link between the inpatient and the community-based services, and between the medical and the social support. Home health is already providing coordination across caregivers by definition with the range of the services that an agency provides. And they're educating the patient, or if you're in just the home care part of the agency, the person on the options and the available resources. So they're really at the center of what's going on. As we see all these new initiatives coming out, there's already a type of organization that's providing a lot of these services. So this is just a little overview for those of you who don't know about Medicare home health. We all think of it as targeting these medically complex cases, but 64% enter the home health service from the community. They're not coming from a hospital. So again, it's your complex person who needs some nursing or they need some therapy, but they're homebound. It's a more complex person. Almost half of them are qualifying for Medicaid benefits along with their Medicare benefits. And even within the episodes that are provided, 11% of the home health aides are providing the majority of services within 11% of the episodes. Well, back when I started looking at the Medicare home health benefit, I think we had about 6% of all visits were aid visits, and that was back in the 90s. And we had this discussion about whether home health aides are actually helping target some of what was called then the long-term care populations. And then this whole discussion about what is the role of the Medicare home health benefit? Is it a long-term care benefit? Is it an acute insurance benefit? And I defer to Judith to answer that. We had a little discussion on the Long-Term Care Commission about the role. So this picture shows a little bit about the average Medicare beneficiary who is following a hospital discharge. So 1 in 5 bennies, 20% of all beneficiaries are going into the hospital each year. Now we're talking about the home health users. So if we look at that far left column, those are the home health people. And I think the big take home there is that 60%, here, let me do this. So 37% of all the people from the hospital are going directly into home health. So it's the second largest post-acute destination. And 38% of them are going to use more than just that home health visit during that transition. So on the earlier table, 25% of those who went to home health landed back in the acute hospital for a readmission. So we know there's some pretty medically, they're either medically complex cases or there are some poor care, and it really raises questions about what's going on. I'll tell you from other research, we know there are both complex and less complex cases. And this just gives you an idea, looking across all those different pathways that somebody could go into the Medicare home health service. 23% of all those people who went from the hospital into a formal service went directly to home health. That was it. They were fine, all done. The second largest group went from the acute hospital into the skilled nursing facility, and that was 17% of those who went to post-acute care. But then the third largest group was acute skilled nursing facility home health with almost 8%. And that's just the beginning of seeing that when we talk about a person's services, it's really an episode. It isn't just one unique service. They're going from one setting into the next, and appropriately so. But the range of mix of services is quite diverse, and we know from other work that much of that's driven by the complexity of the case. But it shows the importance of home health. If you look at the 4th or 5th row down, they've gone from acute hospital into home health, back to the acute hospital. That's 4.5% of the post-acute users. It was 25% of just that group that went to home health. So we need to think about who needs management so that they don't have a readmission that could have been avoided. And not all of those readmissions were avoidable. So what role does home health play in the medical system? Well, if we think about all the different options where they could have gone following the hospital, it's the less intensive, if you will. The long-term care hospitals, the rehab hospitals, the skilled nursing facilities, they all provide 24-hour nursing. So by definition, home health is the least intensive setting, which again goes back to that question of what types of populations are treated in home health. We saw that some of them were pretty medically complex, but there are also other less intensive populations. They didn't need 24-hour nursing, most likely, or they would have been in one of the inpatient settings. Home health also provides a lot of therapy in the Medicare program. Although compared to the other settings, the inpatient settings, it's a much lower level. But if you think again about the population, about the episode of care, that may be a relatively low level of service, but that therapy service may be what's keeping the person mobile in the community or able to use to complete their activities of daily living. So don't be taken aback by the relative intensity of services. It really, I've put these numbers up to show the complexity of the cases treated in this setting and how that plays into the whole continuum of services available. So the next couple slides just talk a little bit about the impact. Okay, so they provide less therapy, but it's a relatively decent amount. What does the home health population look like? Well, we often think about that patient, that person in the home. You're trying to get them back to the community, or they're trying to stay in the community. When we look at how able they were to take care of themselves and perform their activities of daily living, relative to the post-acute care users that are going into the inpatient setting, they're pretty capable at admission. On a scale of 1 to 100, they're going into home health at a 59.6 unit, which is 10 points higher, or almost 10% higher than a patient who's admitted to a skilled nursing facility. So they're pretty able-bodied, and we often think when we study functional outcomes that the person who's more impaired is likely to have the most improvement given their treatment. So then if you look at that change column and you look at the units of change relative associated with the treatment in that setting, you see home health is still a 10-point gain in their self-care scale is a pretty impressive gain. 10 points on the 60 points increases about 15%. So when we talk about value and the different roles of the different providers in that continuum of care, you can see that home health is a pretty important player. So I'm a researcher. I just couldn't put up the unadjusted numbers. What happens when you recognize that home health cases might have different diagnoses, they might be a different age group, they might look a little different than those others? So we ran that model and asked, what's the difference in the gain in self-care ability in the activities of daily living relative to a skilled nursing facility if I control for that difference in patient factors? And in fact, there was a 4-point gain. The average was 12, remember. There's a 4-point gain in the home health patients relative to the SNF patients, that 4.02 on the top row in the second column. But I would also point out that it differs by type of patient. So if you look at the next column with the musculoskeletal, still very impressive changes, but you look at the nervous system or the stroke populations, no significant difference. So again, thinking about that role of home health and thinking about our changing healthcare environment and everybody trying to think about the right service at the right time and the value, you need to take these things into account. Then I also want to point out, given all of these accountable care organizations and these medical homes and all these changing systems, these coordinated care programs, they all come back to case management, to understanding the complexity of the case, getting them access to the most appropriate service for the most appropriate length of time so you avoid the readmission or whatever other quality metric you're being held to. So home health plays a pretty big role there. I think there's pretty consistent agreement across all of the different initiatives about the role of the nurse case managers, which in home health has always been a role. That nurse who goes in and does the initial assessment, they're automatically doing case management. They're thinking about the level of services needed, et cetera. And we see examples. We see examples in bundled payment initiatives, in some of the geriatric transitions programs. So again, whether it's Medicare funded or ACL funded, people are turning to it. And for those of you who missed our December meeting with the LTQA organization, there's a great summary and all of the presentations from groups like Partners or Commonwealth Care Alliance, the different groups that are already thinking about how do I manage these patients to function in this changing world. So what's the potential role of home health? Well, we're talking about a person-centered movement. It focuses on care coordination, on outcomes, and cost effectiveness. Those are kind of the three big drivers. They're part of the triple aim. The new accountability efforts are forcing clinicians. Typically, we think of the doc as a soldier. You know, they're taking care of their patient, they're taking care of the next patient, they're taking care of that. But they're forcing the clinicians to actually follow that patient past their front door and into the community, because now they're responsible for 30, 60, 90 days out, depending upon the program. And when I think about the home health agencies, they're really serving both the Medicare and the long-term services and support populations. They're already in the community, they're providing the resources, and they often know the local populations. They know who's getting pinged back to the hospital and who they need to put back at the top of the chart next week. So they're really a resource that is out there, but to the extent that the hospitals are just learning about accountability, they may be less integrated with the home health agencies in the community. I think one of the things that came out of the December meeting was the role of the community-based agencies, that area agency on aging that's in the community, and often the home health agency and the AAA work together. All these systems require coordination or communication. They all fit in, doesn't matter whether you're talking about the quality strategies or the payment policies, some of the data standardization. We heard a lot this morning about the different initiatives that are underway with creating exchangeable data and personal health records. ONC has a major initiative, which actually Terry is going to talk about. But I just wanted to kind of pull it together. There was legislation that passed last week, or maybe the week before, called the Impact Act. And it directed CMS to move the standardized items into the quality measurement program, into the payment policies, to really nationalize, think about patients in a consistent way. And that didn't just start overnight. So I think this meeting is very exciting because we're at that stage where we have data that we have consensus on how to measure different things like pressure ulcers. The standardized care items brought in the National Pressure Ulcer Advisory Panel, you know, all the leaders in the respective areas. The items have been found to be reliable. CMS has been working on e-quality measures, developing that electronic infrastructure in order to be able to exchange the consensus-based item that is the content to exchange. And it's folding into things like the bundled payment. So the right-hand column kind of gives you a highlight of all of the different areas in the Medicare program where standardized information is being moved into either the quality programs or the payment programs or both. So there's a lot of work underway that is providing resources to the rest of the community to be able to draw down new technologies and apply them in a relatively efficient manner. And I think Terry's presentation will be a good example of that. So what's the future of home health? Well, they're already providing medical and social support services. How many home health agencies can you think of that don't have a home care component or the hospice component? It's all wrapped up. The home health agencies are in the communities, know the local providers. They often know the more medically complex residents. They provide the range of community-based services, the nursing, the therapy, the social work, and the aid services. And they're trained in coordination, which all of those different payment policy initiatives and quality metrics come back to coordination and communication across the system. And then that's just my opinion on the bottom. I think it's a major resource that is underutilized, particularly as we see the change in the healthcare environment to be moving towards managing that patient. Not high-level physician intervention on a weekly basis, but having somebody know what's going on in that household and being able to send in services to avoid a hospitalization if appropriate. So, thank you.